So it's my great pleasure to introduce our next speaker, Dr. Amina Fine, who I had the pleasure of meeting a few months ago and listening to a great talk. Dr. Fine is a physician scientist and assistant professor of neurology and developmental medicine at the Kennedy Krieger Institute and the Johns Hopkins School of Medicine in Baltimore. Her clinical and research interests are in the field of pediatric neurology, with a focus of understanding the pathogenesis and the natural history of leukodystrophies. Her research projects aim to identify clinically meaningful sensory motor outcome measures and neuroimaging markers in ALD, which is another leukodystrophy, and other leukodystrophies. Welcome, Dr. Fine, and thank you for coming.
Again, thanks so much, Radhika, and to the other organizers for having me at the meeting. It's been really an educational day. I've been enjoying all the talks so far. And so this afternoon, actually, it's a really nice segue from what Dr. Tobin just discussed. I'll be speaking with you about my experience with our group at Kennedy Krieger, working on 2 international collaborative leukodystrophy projects, where we're deploying wearable sensors to assess balance and walking impairment. And we're using this method to try to understand more about the natural history and progression of these disorders, and then also to identify clinically meaningful performance measures that have potential to use as trial endpoints. And I think as we go throughout, I'll try to highlight some aspects of our experience that might be particularly applicable in ADLD. Okay, so this is my disclosure. So today I'm going to describe our process of developing quantitative outcome measures in leukodystrophies and how we've expanded our international network to try to capture as many individuals and phenotypes of these disorders as we can in the situation where these are both very rare. So I'll use case examples of 2 leukodystrophies, LBSL, or leukoencephalopathy with brainstem and spinal cord involvement and lactate elevation, which is a largely pediatric onset leukodystrophy, and adrenomyeloneuropathy, which is adult onset. And so through these examples, I want to address the questions. First, what can we measure that's sensitive to change? What can we measure that might be clinically meaningful to patients? What are some methods that might apply across ages and disability levels? And then I'm going to be focusing on the data that we've captured through teleresearch at the patient's homes using wearable accelerometers. Actually, I should say it's flexible. It can be done in the home or the clinic. And then also show our approach of training other investigators in wearables data collection, which we've standardized and been using that with success over the last few years. And I'll show some data analysis from the international collaboration, some published and some unpublished work. And finally, just talking about how some of these concepts and approaches might apply in ADLD. So first example is LBSL, leukoencephalopathy with brainstem and spinal cord involvement and lactate elevation. So LBSL is ultra rare. It's an autosomal recessive leukodystrophy. And the hallmarks are, so brain and spinal cord white matter changes. So you get these T2 hyperintensities in periventricular and deep cerebral white matter, cerebellar white matter, and then also in the brainstem and universally throughout the dorsal columns. Sometimes the corticospinal tracts are also involved. And so the DARS2 gene variants are responsible for this diagnosis. Most of the time they're heterozygous compound mutations. And DARS2 encodes mitochondrial aspartyl tRNA synthetase, which is an enzyme that's really critical for translation of mitochondrial respiratory chain complex proteins. So the onset of LBSL is largely pediatric, infantile through late childhood, even though there are some adult onset cases. And generally we know in terms of prognosis that the earlier the onset of symptoms, especially early infantile or really antenatal onset, where there are significant changes in the brain even prenatally, these result in greater disability, morbidity, and mortality. The progression rate is variable, although often slow in childhood onset. And the key features are ataxia. So this is due to the dorsal column dysfunction as well as cerebellar involvement, tremor that affects upper extremities as well. And loss of ambulation is really a major concern for patients, with about half requiring a walk aid by adulthood and 13% being wheelchair bound by adulthood. So from the patient perspective, what does it feel like to live with LBSL? We are still working on this closely with Cure LBSL, the patient advocacy organization. They're really amazing, and their director of patient engagement recently sat down with dozens of patients and families across the world and who shared their personal experiences through patient voice sessions. So either a group or individual sessions. There were hours of recordings, and sort of what came out of that was this beautiful illustration that essentially it shows what are some of the major concerns that patients deal with in their day-to-day life. We're really trying to make sure we keep the patient voice front and center when guiding our research priorities, and eventually for evaluating the effectiveness of any treatments. So key were mobility and balance issues, tripping and falling, loss of independence due to these issues. Sleep, energy, and fatigue were high on the list. Patients reported concerns with GI, constipation, reflux, failure to thrive, other nutrition concerns, mental health, and self-care resources were a major need. The feeling of stigma, being left out, really not having certain barriers from participation, especially physical barriers, headache and neuropathic pain. And then most of the time, so survival is a concern primarily for the earliest onset cases, and about 10 to 20%, there is mortality. And so some families, for them, there are other major concerns: respiratory sufficiency, seizures, other things that are life-threatening, and eventually sometimes losing a child or a loved one to LBSL. So these are the concerns in their own words, I think illustrated in a very effective way. And we know that even though this is specific to LBSL, a lot of these above experiences, symptoms and themes are relevant to many leukodystrophies, including ADLD. So right now, there are no FDA-approved treatments for LBSL, even though there are multiple possibilities in the pipeline at this time. And so our goal is to establish clinically meaningful quantitative outcome measures for trials. So we've been working on this for the last few years. And our approach really has been through virtual research visits because the disease is so rare. Patients are spread throughout the country and internationally. And this has helped us we think, to increase access to participation. And we do visits every 6 months. We've had really great compliance with our sort of small but mighty group. So I'm going to focus today on the wearable sensor testing, which we do, again, virtually and in the clinic to test walking and balance. But we also use a standardized ataxia rating scale, the SARA. We collect detailed interview information about clinical, how things are doing, clinical problems, developmental and school issues. There are patient-reported quality of life surveys. Because I mentioned there are fine motor concerns, we do a drawing test, the Archimedes spiral, and then try to also do, at each iteration, each visit, understand what's happening with global gross and fine motor function. So it's really a comprehensive program, we think. So I just want to introduce you to some of our cohort at Kennedy Krieger first. And this is an ongoing cohort. There are 19 people enrolled. This is a young group with a mean age of about 9 years, age range from infancy through middle adulthood. The age of symptom onset is actually pretty balanced, so anywhere from that early infantile period through adolescence. And it's about half of our patients that had onset younger than 18 months of age. In terms of the gross and fine motor function scales, the scores are moderate, really exactly middle of the range. The SARA ataxia scale is on a range from 0 to 40. So on average, the patients have moderate symptoms with their ataxia. In terms of walking status, 63% are walking independently, 3 require an aid, and 4 aren't walking. So there are 2 that they're actually in late toddler age, but still have not obtained the ability to walk, and 2 have lost it and adulthood. In terms of orthotics, the need for bracing is very common in 2/3. Another 2/3, and this is something actually not really reported in literature, we've discovered this over time in our natural history study. About 2/3 have what we call motor crises, where in reaction to or associated with a fever, an illness, concussion, a minor insult such as that, there's a regression in physical and motor ability and a worsening of tremor, and this usually resolves within weeks of the illness resolving. And then about 60% of our patients take some iteration of mitochondrial supplements. In terms of more things related to developmental delays in school, about 2/3 have a history of gross motor delays, 2/3 fine motor delays. Speech delay is also common, and almost all of our patients through the school years had issues with writing. About 1/3 have documented learning disabilities, and about 1/4 have more serious cognitive concerns, such as mild intellectual disability, autism, or an ADHD diagnosis. So related to all of these concerns, about 3/4 require some sort of a formal education plan of support. So just transitioning a bit to the wearables for balance and walk testing, we use the Opal's wearable triaxial accelerometers. Their validity has been established in comparison with the gold standard equipment in a motion lab, such as the force plate and 3D motion capture systems. And they've been used in various both pediatric and adult neurologic disorders and ataxic disorders. So again, the advantages are that they can be used in person or shipped home, helping us remove some barriers to participation. They allow us to frequently collect data. And I think a major advantage is that the tests are actually supervised directly by our staff in real time. So this isn't a passive monitor that the person wears over some hours or days. This is a session that we actually carve out time. It's a clinic visit. It takes about an hour, and we give setup instructions and walk them through the whole process. It also allows us to do some quality check in real time. So the wearables are these, again, are 3 watch-sized battery-based accelerometers. And for the test, we send a kit to the participants' homes that includes, so the Opal's kit, a remote controlled webcam, a laptop, a device manual that explains everything in layperson language. Everything is very clearly labeled in terms of the sensors. And we have a demo video for people to, if they really want to get a sense of how it should all be set up in advance. So on the next slide, hopefully this works. I just want to show a couple clips from a video that our excellent research coordinators made, demonstrating first our 2-minute or self-selected walk test. And so he's walking back and forth on a clearly marked straight level pathway. And then the sway tests. So there are 4 sway tests. There's a foot plate so that there's a standard width that people are standing with their feet apart each time. The Opals are on the dorsum of the feet, and they're instructed to look straight ahead and be as still as possible for 30 seconds. And this is over 2 trials. Okay. So we got a great start in the US, but after a couple of years, participant enrollment slowed. So we considered how we might be able to include international patients who by that time were hearing about the study, emailing us, sending inquiries. Unfortunately, we couldn't figure out an IRB approved mechanism to recruit outside the US. We also looked into shipping the Opals between countries, but this was really prohibitively expensive and also risky. And so at the United Leukodystrophy Foundation conference in 2019, we connected with some colleagues and investigators at the Amsterdam University Medical Centers. I should say we had really a leg up because the head of this group, Dr. Mayo Vanderknop, was the person who first described the disorder through MRI pattern recognition about 20 years ago. So they were already well connected with a group of patients. And so our colleagues did agree to start a parallel IRB protocol to ours. So by the time their IRB was approved in 2020, in spring 2020, we were right in the middle of the pandemic. So we pivoted at that time to remote training sessions, which has actually been really a good strategy for us over time to try to accelerate our collaborations. So we just essentially follow this approach of orienting to the OPAL system and software. We walk our colleagues through how to set up the equipment and software for the testing. We have them practice testing as the subjects and then have them administer the test to us. And we basically do this repeatedly until there's demonstration that they're confident with the techniques. So then we started to think, well, where else are we able to do this? So Cure LBSL, again, was really instrumental in helping establish new international partners. So in 2021, they were awarded a RARES1 grant from the Chan Zuckerberg Institute, and this funded, among other things, a new international contact registry and a genetic prevalence project with the Broad Institute with the aim of equity and network building. So these efforts did help us to locate more interested individuals and learn where people with LBSL might be living. So we next reached out to investigators in Finland, where there's a high carrier rate of DARS2 variants, and there was great interest, and we activated a site with them in 2023. So they've since tested 8 patients, and their medical student actually just came to Baltimore for several months to do a rotation with us for further training and data analysis. I'm actually going to be showing some of her really nice figures in the next few slides. And then we've since tried to expand the network further. We connected with a group in Brazil. In the last year, their IRB has been approved, and we're just at this point trying to, pending a transfer of the OPALS kits through customs, just trying to figure out a way to accomplish that, but they have a ready group of people waiting to join the study as well. So I'm going to just show some of the walking data across and balance data across the 3 sites that I mentioned, the US, Amsterdam, and Finland. So in terms of age distribution, so there were 23 people who were able to complete all the tests. We have 34 in the total natural history study. And the ages range from actually 5 until the mid-50s. And actually this group was exactly half of the patients, or just about half of the patients, were under age 18 and half over age 18. I'm not showing it, but there's no male-female predominance. Transitioning to looking at the sway tests, here are the 4 tests we've implemented across our sites. And I'll just say, I'll show these video clips, and above, this is the sway path of this young lady on the right compared to her age and sex matched control on the left, and this is as though you're looking from the top down. So this is stance first with feet apart, eyes open, which is sort of the easiest condition to perform. Feet apart, eyes closed. More difficult is this is challenging proprioception or the dorsal column dysfunction we see in LBSL. Feet together, eyes open, which is challenging more cerebellar input, and then feet together, eyes closed. And you can see this child's mother standing behind with her arm ready because this is a very difficult condition to perform. Okay, so now looking at the full cohort of 23 patients, what we found first is that the sway amplitude during the standing balance test is significantly higher for LBSL patients across all conditions, but especially in the condition with the feet together, eyes closed. And then we wanted to further calculate a Romberg quotient to really specifically focus on the dorsal column dysfunction. And so this is the ratio of the sway area with the eyes closed divided by the sway area with the eyes open. And we saw that the mean Romberg quotient was doubled for our LBSL participants across sites and ages. And so importantly, taken together, these results across our institutions really strongly enforce that the degree of sway with the eyes closed really should be further investigated as an indicator of disease progression. So then for the 2-minute walk tests, this is a demonstration. They walk back and forth between 2 points on a about a 20-foot walkway, which has been realistic to find in people's homes. This is a 10-year-old girl with a moderate SARA score, having some stumbling in her gait and hesitancy in turns. The gait cycle is the period from the foot first making contact with the ground until the same foot makes contact again. Excuse me. I'm getting over a cold. So what we found was that the LBSL participant gait speed was slower by a large clinically meaningful margin of about 0.2 meters per second compared to controls. So for perspective, and I should say the mean is the dotted line, this means that if you calculate this forward over 2 minutes, this was a difference of about 80 feet between these two groups over the 2-minute period. We saw double support, or the time with both feet spent on the ground during the gait cycle, to be elevated. LBSL patients had shorter stride lengths. And this didn't translate to a decrease in cadence or the steps per minute, but this might be because the cadence can voluntarily be increased to compensate for shorter strides. We also looked at a few variables that are a little less traditional, such as the elevation of the step at mid-swing relative to its position while standing. We saw significantly higher foot elevation for LBSL. This can also be considered a high steppage gait. And you can see it in disorders with cerebellar ataxia, spinal cord injury, or peripheral neuropathy. The high step is basically a compensation to allow the foot to clear the floor during a stride. The lateral step variability looks at the wide variability in stepping patterns seen in ataxia. And we saw an elevation here. It basically indicates a veering or stumbling gait. And then we looked at foot angles. So the foot strike angle is the foot angle as the heel strikes down at the end of a gait cycle, and an angle closer to 0 indicates more of a flat foot landing. We saw this angle was significantly smaller in our LBSL cohort, possibly due to weakness or reduced flexibility. And then the toe-off angle, sort of the corresponding angle, was also smaller. So this is the angle of the foot during step-off as the stride is initiated. And again, a smaller angle can be seen with spasticity, weakness, or impaired proprioception. So in the last few slides, I just wanted to briefly highlight our experience with another joint Kennedy and Amsterdam project, this time in the adult onset leukodystrophy AMN. So the AMN, as you may know, is one of the phenotypes of X-linked adrenal leukodystrophy, which is really an aggressive cerebral disease in boys and can be in men. So the hallmarks of adrenomyeloneuropathy are variants in ABCD1. There is accumulation of very long-chain fatty acids with myelin damage. Again, there's adult onset, both in males and females, even though it's X-linked. Excuse me. So, and then we know there's a distal axonopathy that affects dorsal column function and cortical spinal tracts. So in some ways similar to LBSL and even ADLD, there's progressive disability related to sensory ataxia, weakness, and spasticity. So even though a lot of progress has been made in this disorder overall, in AMN, we are still working to find effective primary clinical trial endpoints. So there was a recent study of an oral medication, leukodystrophy, in men with AMN. And unfortunately, the primary outcome, which is gait speed during the 6-minute walk test, was not met. However, it looked that like an investigation of sway in these participants, would be a potential outcome measure to further investigate. So we've been doing that and trying to understand how sway is clinically meaningful in these patients. So in this cohort, we found, first of all, that sway with the feet apart and eyes closed is correlated with the EDSS Global Disability Score in both males and females with ALD. So I know the EDSS was mentioned way back in the first talk. It's often used to measure disability in adult neurologic disorders, multiple sclerosis, et cetera, and it's on a scale from 0 to 11. We only went up to 6.5 because these are the people that are still able to walk with an aid. But we just saw a clear relationship of increasing sway being associated with greater disability, and this was both for men and women. And there was also a relationship where we saw a much greater degree of sway amplitude in those who required a walk aid versus those who did not. Next, we found that the 6-minute walk test gait speed, so the 6-minute walk test is the fastest possible walk test. That was done in Amsterdam. At Kennedy Krieger, we did a 2-minute walk test, a self-selected pace, to see what the differences might be between those measures or those methods of testing. And we found a clear relationship with the 6-minute walk test and the EDSS. None for the 2-minute walk test for the males, but this also was clearly limited by sample size, and we're collecting and evaluating more data. For the women, we found that gait speed was correlated with disability score, regardless of the paradigm. Coming back to the toe-off angle, we also did find that this correlated with disability in AMN, and this was for both men and women. Just for perspective, about 45 degrees is the normal toe-off angle. So some patients in the upper ranges of the EDSS scores have really a huge increase in this angle decrease by about 15 to 20 degrees. Again, this toe-off impairment can indicate weakness at push-off as the swing is initiated, or spasticity, which might cause a decreased range of motion at the ankle or a smaller ankle. So the AMC group sent a really ambitious survey about falls to their male AMN participants. Of course, falls are huge in terms of morbidity and even potentially mortality. They queried falling every 2 weeks over 9 months. Did you fall? Did you not fall? 25 of the patients consistently reported falls and 14 never reported falls. And what we found was significant modest correlations of sway with falling in these men and a moderate correlation of the gait speed with falls. We also saw in these men that quality of life correlates with the sway to a modest extent in AMN, especially for physical functioning and general health. So in conclusion, we demonstrate a feasible approach to train clinicians across international sites to apply wearable technology to test leukodystrophy patient walking and balance. And this can be done in multiple settings, including at home. We saw that sway and gait variables distinguish LBSL patients from healthy volunteers, and a subset of sway and gait variables correlate with disease severity, device use, falls, and quality of life in AMN and adult leukodystrophy. So we're continuing to look at the longitudinal performance of these sway and gait measures with the hope they could be potentially endpoints for trials. And we have some promising data so far in the Kennedy LBSL cohort. We're just waiting for some of the other sites to catch up with their testing. We are continuing to engage with the FDA. There was a patient listening session for LBSL held last year, continuing those conversations and trying to keep the patient voice central. And just in terms of, just setting us up for the discussion later, just emphasizing that there are some phenotypic similarities existing across these leukodystrophies. Ataxia, tremor, sensory changes, weakness, and spasticity are all involved, and this is because both the brain and the spinal cord white matter is affected. Progression can be variable and sometimes slow, which obviously makes things more challenging to find sensitive markers of change. I know that certainly in ADLD, there are some patients with dementia and more severe cognitive impairment, but I know that at least in the earlier stages, sometimes there's preserved or mild cognitive impairment so that patients actually could participate in the simple instructions for these tests. And then there's this very interesting challenge of symptom exacerbations, which we haven't fully gotten into, but that represents another opportunity to try to track what's happening during those. Okay, so thanks very much for your time and attention. And again, great appreciation to my whole team at Kennedy Krieger, at Amsterdam UNC, and at the University of Helsinki. This has been really an extraordinary effort over the last few years. And, we look forward to continuing the work. Thanks very much.
Thanks very much, Dr. Fine.
Yes.
What I wondered was, in your data, have you seen that the gait analysis gives you better outcomes than, or better markers of outcome than simpler measures? So like just asking like a PDDS or doing a time 25-foot walk, like are we getting additional data from these costly and costly tests, basically. And then the other thing is, have you been able to identify any patients very early in the disease where like the clinical exam is normal, but that you do the gait analysis on them and that it's abnormal?
Those are really great questions. So for the first question, the short answer is yes. So, and we really send a lot of measures. The SARA, the Standardized Assessment and Rating of Ataxia, we've been, I'm not sure, I didn't show any data from that, but we've been looking at it consistently from the literature in spinocerebellar ataxia and Friedreich's ataxia. We had a sense that it might not perform so well with early disease or very mild disease, and that's panned out. So again, I didn't show any longitudinal data, but I think where the wearables are an advantage is that so far, even in our small LBSL cohort, we are seeing it takes about 18 months to 2 years, but there is a significant change in the stride velocity. Whereas over that same period or over 2 years, I'm seeing the SARA change less than a point. And then also looking at some of our other global disability scales. I mean, they're good for other reasons, but like the gross motor function classification scale, the manual ability classification scale, these are really not they're changing. They're not really changing for the patients over a 2-year period, maybe over a 4 to 5 for those who've been in it the longest. So I think there is some advantage, mostly for change. And then, as I mentioned, this toe-off angle was a surprise to us. Like, retrospectively, it makes sense physiologically, but, I think it represents, because you can look at toe-off angles, because you can look at foot height, because you can look at some of these other measures that you can't capture just with a timed walking test. Those might ultimately pan out to be the ones that change over time. And so that's why I think this next phase is really important in seeing how they perform longitudinally. Hope that answers the question.
It does. Thank you.
Welcome.
An easy question for me. When you said you are doing remote wearables, do you teach the family, or is it like monitored over a video visit or something like that? Like, how exactly is it done?
Yeah, no, it's a little bit of both, really. So, as I mentioned, we send there's a lot of prep work and a lot that we send in advance. Some people probably completely imbibe and they're super prepared, they study it, and others probably don't at all. But we do send, again, a video demonstrating how to set up everything in their house and put on the equipment, how the tests work. And then there's also a manual that we give that's in simple language with pictures. So those are the ways we try to do some like passive education, and then we carve out time. For a new family, maybe it's an hour to an hour and a half, and we do remote takeover. So we're just like this on Zoom. They just have to figure out how to pull up Zoom and share their screen. We take over, set up the tests, and we're sort of watching everything. If they put on a sensor incorrectly, we'll probably see it, but if not, there's an error message to say they put it on backwards. So that's what I meant in terms of there are great opportunities with the Opals for quality improvement in real time to make sure you're getting high quality data. And we record the sessions as well, so that if something looks unusual in the data analysis process, we have notes and we can go back to the recording to understand if there was some kind of an error.
And then one follow-up question to that. How frequent are your wearable recordings being done for AMN?
So for AMN, they're every year.
Okay, thank you.
You're welcome. And that I should say that part of that is due to we had some information in advance, essentially with a long history of motion lab assessments being done in AMN through a previous clinical trial. And we really didn't have much evidence that things would change in a 6-month period. So we kind of took cues from that previous literature and spaced out the intervals. Yeah.
Makes sense.
Mm-hmm.
I think that's all the questions we have for you.
Thanks so much.